Doctors, let's jump right into a 5-star, highly tested topic for your NEET PG and university exams, intrapartum fetal monitoring. We're going to break this down conceptually. Because look, whether you're solving MCQs or handling patients on your labor ward duty, your fundas on this literally need to be crystal clear. Let's get started. Here's what we're covering in this explainer today. We'll quickly move through fetal oxygenation in labor, methods of fetal surveillance, decoding the CTG baseline, understanding fetal decelerations, ACOG categories and management, and finally, advanced fetal monitoring techniques. All right, Section 1, fetal oxygenation in labor, specifically the pathophysiology.
So why exactly do fetal heart rate drops happen in the first place? Let's trace the pathway. During a uterine contraction, blood vessels get squeezed, right? And that causes decreased uteroplacental blood flow. Now, a normal healthy fetus tolerates this perfectly fine. But if we have a compromised fetus, say IUGR or preterm, this drop leads directly to fetal hypoxia. This hypoxia then depresses the fetal brainstem, giving us that drop in the fetal heart rate, which we call a deceleration. The concept is super simple. A deceleration is basically the fetal brain's cry for oxygen.
And guys, we must intervene fast. Missing this hypoxia cascade leads to really severe consequences. It starts with metabolic acidosis, progresses to neonatal encephalopathy, and finally, that dreaded long-term sequela, cerebral palsy. This is exactly why we monitor so closely.
Moving on to Section 2, methods of fetal surveillance, routine versus high risk.
Now, for your low-risk cases, routine intermittent auscultation is totally fine, but pay attention to these timings on the screen because this is a direct MCQ. For low risk, you check every 30 minutes in the first stage and every 15 minutes in the second. But for high-risk patients, we really intensify. It's every 15 minutes in the first stage and every 5 minutes during the second stage of pushing. Don't forget that. For high-risk continuous monitoring, we bring in cardiotocography, or CTG. The setup is straightforward. 2 transducers strapped to the mother. The machine plots 2 graphs simultaneously. The jagged line you see on top is the fetal heart rate, and those smooth hills at the bottom, those show the maternal uterine contractions. Honestly, comparing these 2 lines is the entire secret to intrapartum fetal monitoring. Okay, Section 3, decoding the CTG baseline. Normal versus abnormal. First up, normal fetal heart rate is between 110 and 160 beats per minute. But the absolute 5-star point here is baseline variability. See those irregular fluctuations? A normal variability of 6 to 25 beats per minute is literally the most reliable sign of a normal umbilical cord pH. On the flip side, absent variability is your most reliable sign of fetal hypoxia. Definitely mark this point for your exams. So what happens if the baseline shifts? Well, bradycardia, which is less than 110, can just be simple head compression, or it could be dangerous hypoxia and congenital heart blocks. But tachycardia, anything more than 160, should immediately make you suspect maternal infection. Keep in mind, maternal fever and chorioamnitis are classic MCQ answers for fetal tachycardia. And that brings us to the dreaded sinusoidal pattern. Notice this really smooth, undulating wave of 2 to 5 cycles per minute. It completely lacks that normal, healthy, jagged variability. Listen, if you see this on your ward duty, alarm bells should be ringing. It's a strict Category 3 CTG and requires an immediate emergency C-section.
But why is it such an emergency? Basically, that smooth sine wave equals severe fetal anemia. The fetus is actively losing or destroying its RBCs. The classic causes you need to remember are Rh incompatibility, parvovirus B19 infection, vasoprevia, and twin-to-twin transfusion syndrome.
All right, let's jump to Section 4. Understanding fetal decelerations, early, late, and variable. Before we even try to classify them, you have to memorize this strict definition. What exactly qualifies as a deceleration? It's a drop in the fetal heart rate by at least 15 beats per minute, lasting for at least 15 seconds up to 2 minutes. Just always remember the 15 by 15 rule. Now really observe the relationship with the uterine contractions at the bottom of the graph. On the left, the early deceleration's lowest point, the nadir, perfectly matches the contraction's peak. It's almost a mirror image. But look on the right, the late deceleration is shifted dangerously. The drop begins only after the contraction has already peaked.
This right here is a very common student doubt. Those early dips, the mirror images we just talked about, are just benign head compression causing vagal stimulation. There's no need to panic. But the late dips, those delayed onset ones, they signal ominous uteroplacental insufficiency. Essentially, the placenta is failing during the stress of a contraction.
Then we have the variable deceleration. Unlike the gradual U shape we just looked at, notice this sudden, really sharp V-shaped drop. It's completely erratic. It has a variable relationship to the uterine contractions. Sometimes it happens right with them, sometimes totally without. These sudden, sharp drops are mostly mechanical in origin. They're driven by umbilical cord compression. Think about it logically. If there is oligohydramnios, there's no fluid cushion, right? So the cord just gets squashed easily. You'll also see this happening in postterm pregnancies and developmental cord insertions.
Moving to Section 5, ACOG categories and management protocols.
So ACOG divides these traces into 3 clear categories. Category 1 is normal and reassuring. Category 2 is suspicious. It's everything in between that needs close monitoring. But Category 3, that is non-reassuring. Think absent variability with late decelerations or that sinusoidal pattern we discussed. Category 3 means you shift the patient straight to the OT for an emergency C-section.
But wait, before you run to the OT, you absolutely must perform in utero resuscitation to buy some time. Step 1, stop oxytocin instantly. Step 2, turn the mother to the left lateral position to relieve IVC compression. Step 3, start oxygen by mask. Step 4, run IV fluids. And Step 5, give tributylene if needed to relax the uterus. The goal here is to maximize oxygen delivery right now.
Finally, Section 6, Advanced Fetal Monitoring Techniques. Now, if the CTG is an ambiguous Category 2 and we aren't sure, we use the fetal scalp protocol. First, we do digital scalp stimulation, usually using Alice forceps. If the heart rate accelerates by more than 10 beats per minute, it guarantees the scalp pH is above 7.2. Basically, the baby is fine. But if there's no acceleration, we make a tiny 2mm scalp incision for blood. If that pH comes back less than 7.2, we have confirmed fetal acidosis. At that point, you go for immediate delivery. I'm going to leave you with this final thought to chew on. Earlier, we said a deceleration lasts up to 2 minutes. But what if that dip lasts for more than 10 minutes? Well, it's actually no longer a deceleration. It is a completely new, dangerous baseline change. The environment for that baby has permanently shifted. Master these concepts, stay sharp on your ward duties, and you won't just crack your exams, you'll actually save lives. Thanks for tuning into this explainer, and I'll catch you in